So thank you very much for the introduction, folks. I really appreciate it. So my name is Niall McNelis. I'm a physiotherapist by trade, but over the last kind of 5 to 7 years, I've worked a lot in terms of the concussion space, around research, around the sideline identification, as well as the assessment of concussion. And I suppose over the last 2 or 3 years, we've noticed a lot of change in the concussion space around how we assess them, how we stratify concussion, how we rehabilitate concussion, as well as how we return concussions to play. I suppose the really important point to get across is when it comes to concussion and when it comes to your children's safety, there's no such thing as a silly question. I'm also aware that I'm talking about a complex neurophysiological injury this evening in a heavy Irish accent. So if you lose me at any stage, don't be afraid to say something, put up a hand, shout out. Because as I say, there's no such thing as a silly question. All right? So just to begin with, what is concussion? So the big change that we've seen in the last few years is that concussion is a structural brain injury. For a while we were wondering whether it was just an abnormality or a dysfunction or a disturbance. We now know that there absolutely is structural damage when it comes to concussion. It's minor, so you don't see it on any sort of imaging. If you did, it would be a traumatic brain injury. Given that you can't see anything on scans, it's referred to as a mild traumatic brain injury or sports-related concussion. When it comes to concussion, what we also know is that there is a physiological reaction. So a bit like rolling your ankle, there's going to be swelling, there's going to be pain, and those things account for a lot of the symptoms. So when it comes to the brain after concussion, there's altered blood flow, there is a bit of inflammation, there is an ionic imbalance and an energy mismatch. And all of those account for the longevity or how long the symptoms last for, but also it accounts for the individual symptoms that you get. So we're trying to get a real understanding of what concussion is, but these are 2 or 3 of the massive changes that have come around concussion. So it is a structural injury, we understand why you get symptoms, and it's also important to know that the signs and symptoms are individualized. There's 7 separate subtypes of concussion, so not every single one is treated the same. Though the protocol, it's always 21 days, which is something that I have a bit of a bugbear with. Not all concussions are the same and should be treated the same. You have to identify it, which kind of concussion it is, and then treat it and rehabilitate as such. All right? So, why do concussions happen? What are the risk factors? So the first one is previous concussion. So whether you've rolled your ankle, whether you've strained your hamstring, whether you have a bad back, that all increases your risk of those particular injuries. So if you have previous concussions, you're more likely to have more concussions. When it comes to female athletes, we know a lot of the research at the moment is focused on why females are at a higher risk than males. It's for multiple reasons. One, female necks are a bit more slender and less strong than male necks. Second is that during the late luteal phase of the menstrual cycle, higher progesterone increases brain vulnerability to concussion. The third one is that the individual brain anatomy is more susceptible to concussion. And then the fourth thing is that with, let's say, lesser access in the lower levels to coaching and appropriate coaching around the tackle area, around falling proficiency, that can all increase risk of head impact events. Next one is neck strength. So in the female athlete, massively important to be working on neck strength. In male athletes, it's up for debate at the moment. Tackle technique, being tackled is much more to do with rugby, more so than AFL. In AFL, it is also important to make sure that we're tackling well. If your child does have ADD, ADHD, neurodivergence, that has an impact on brain building, brain formation, brain whatever. I'm sure Fiona can talk a bit more extensively about that. But it means that the brain can potentially be a bit more vulnerable to head impact events, and the symptom trajectory, the symptom type can be a bit more different than, let's say, someone like myself who's not neurodivergent. Last thing is grass versus turf. So there again, it's up for debate, but artificial turf potentially has a higher risk for injury versus grass, let's say, when it comes to hitting your head on it. Big question I'm consistently asked is, does headgear, scrum caps, although you see the big impact helmets in the NFL, do they prevent concussion? And the answer is, we don't know, likely not. In my opinion is, it doesn't. What it does do is it can often give a child or an athlete more confidence to put their head where they shouldn't, and therefore could potentially be detrimental. But in terms of, if you see guys returning from concussion and wearing headgear, you see it in soccer all the time, we don't know if it gives any impact. It doesn't, and more than likely not, because it's an acceleration, deceleration event rather than an impact. So, why is concussion? So you see consistently through the media, oh, this concussion was missed, this concussion was missed. What makes concussion such a tricky injury to A, diagnose, but also identify? So the first thing is that concussions happen at high speed in chaotic events, in chaotic circumstances, where the view of on-field instances may not be clear. This happened to me multiple times. What we also know is that players are competitive and they can often fudge the truth when it comes to telling physios, nurses, parents, friends about having a concussion, about having symptoms, because they want to play on, because they want to keep cracking on, and because they don't understand what concussion could potentially mean. The last thing is that we have, in terms of the time for on-field assessment in sport is somewhere in the region of 30 seconds to 90 seconds. Then the average in soccer is 57 seconds. So we have a complex neurological injury that's extremely specialized and extremely individualized that we're trying to assess or identify in less than a minute. So it's a very tricky injury to identify early doors, but once we do identify it, we know what we have to do. So what I would say in terms of this is what we're trying to do this evening is identify the main impacts or identify the main sources or the main signs and symptoms of concussion and what we're looking for. So I'm just going to pause for a moment. When I look at a head impact event, I break it down into the first 7 seconds. So what are we looking at over those first few seconds? So in terms of this, the first video is about the immediate response. So you have a head impact event or a serious insult to the body or a serious body hit. What you have is the player falling to the ground stiffly, which you're going to see in this. A player not protecting themselves as they fall into the ground. They may begin to seize. It's not serious. It just needs to be dealt with appropriately. And if the player remains motionless on the ground. So we're going to see all of these through this impact event here. Is this in rugby? I apologize. I thought I had put this here together. Sorry. Now, so we see the ball comes across the line, and we can see head impact event, falls stiffly, and then remains in the timber position on the ground, and then remains motionless. So this ticks all of the boxes, and then we can see the medical staff come on and are really, really good. So the first one stabilises the neck, and then they're soon after that they're doing their assessment. So we see head impact event, not protecting yourself falling to the ground, remaining motionless, potentially into the timber position. All right, so that's the first few seconds. Next is on return to the feet. So I challenge anyone to see this impact before it happens. So you can see player on the left gets up and falls. So we're going to see this again in a moment. Again returns to his feet, again falls again. So we have unsteady when attempting to stand. Using your hands, you're trying to crawl up to get back to your feet, falling back to the ground, a vacant look when he's going on, and then the player returns to his knees. So what we see within this is, again, it's pretty obvious. The head impact was missed, but the actual sequela or the result of it is plainly seen. So I'm sure I think they're going to show the actual impact event here, and it's pretty nasty. It's basically it's a knee to the head. So we might just skip on because we don't need to see that. It's a Wednesday night. So on return to play. So again, you will often see a head impact event. The player will return to where they came from, and then you'll start to see issues when they get back there. So we can see here a player clearly confused, so not returning to the right area that they should be. A player is not properly tackling, is not properly hand passing, is not properly participating or performing in the game. We have a player not immediately moving back to the correct position. So getting back away from the event and then wondering where they are and then eventually orientating into where they should be. And then a player not even trying to participate. So a player that walks away, gets away from the action, tries to protect themselves. These are all obvious signs. So what you can see here, this player is going to go off. So you can see the ball is nowhere near this player. The ball is nowhere near it. He attempts to catch it and then falls over. So clearly obvious this player is not right. Ball is nowhere near him, completely disoriented and falls over. Which is obviously one of the more comic ones we have. Now, so as I've said before, concussion is complex. It happens quickly, it happens when we can't see it. So it's then when we're talking to our son, when we're talking to our daughter, when we're talking to a player, it's, does this player seem right to me? If you know them, does this player seem right to me? If you don't know them, does this player seem right given the context of the situation? So this is a really interesting one. I only found this about 2 weeks ago. So it's query, it's possible confusion, possible trouble concentrating, possible remembering, possible sensitivity to light or noise, and altered behaviour. So this is a post-match interview. I think they've just won. So this player should be over the moon, should be elated, and just watch. So we can see there is run the hand through the hair. Now he's better hair than mine, but when it comes to this potential sensitivity to light, he's not really focused on what he's being said. He's looking all over the place. It's trouble concentrating. But even if you were talking to this fella outside a pub or talking to him in a coffee shop, you'd say something isn't right here. So if you see something, say something. All right. So these signs and symptoms that I've gone through here are blatantly obvious. I've picked videos to show that they're blatantly obvious in these scenarios. But when it comes to concussion, only 1 in 3 are knocked out. And up to only 76% are caught at the top level, whereby you have concussion spotters, you have independent matchday docs, you have video replays, you have referees, you have full medical staff. In that scenario in rugby union, only 76% of concussions are caught. And what we know about concussion is that normally only 1 in 10 are reported when it comes to going to A&E and stuff like that. So concussions are missed. So what we rely on is we rely on our trainers, we rely on people who care about our kids to look after them. So the big, overwhelming, highlighted, in italics, spelled correctly, everything, if in doubt, sit them out. This is not the AFL. So we need to protect our kids. If they are concussed, if we are querying a concussion, we got to respect whoever's made the call, and then we look after them. May not be what we want to hear, but it's what we need to do. Because we know that this is a complex physiological injury that needs to be looked after, and then we can return them to play. So what are we looking for? What are the clues? So loss of consciousness, that only happens in 1 to 3% of cases. We have line motionless on the ground, unprotected fall onto the ground, dazed facial look, disorientation, seizing, less likely. You will unlikely see these in most concussions. These are the absolutely obvious ones. Let's get them straight off. Slow to get up after a direct hit to the head is a big one for me. Unsteady on your feet and potential having a facial injury. Now, let's say someone has got a concussion and we're worried that this could escalate into something more. What are what's called our red flags? So when is it right? Let's get them off the pitch and straight to A&E if they're walking around, or if they are on the ground, when do we call the ambulance? All right. So the first one is neck pain or tenderness. If your child is on the ground and has neck pain or tenderness after a significant head impact event, we don't move them. We let the ambos and we let the trainers look after them. We don't get them up and see if they can shake it off. We make sure that we're not dealing with anything more serious. Next one is if a child starts to seize, we let the seizure happen and then we get in and we stabilize the neck once the seizing is stopped. Seizing will often only last a few seconds, nothing crazy. Loss of vision or double vision, loss of consciousness, you always get them to A&E. If you notice that, let's say you've had a head impact event and symptoms start to get worse, what we do is we say right. And if they get worse quite quickly, what we say is right. Let's get you to, in Ireland we call it A&E, here you call it ER. Emergency room? Yeah, brilliant. How different our cultures are. Next one is repeated vomiting. So if you have a concussion, you're allowed to get sick once. Repeated vomiting, straight to ER. Next is you have severe worsening headache. If you start to get worse, significantly worse, very, very quickly, straight to ER. Visible deformity of the skull, you don't move them, you get the ambos involved. Right, so when it comes to, let's say we've identified the concussion, or potentially we've removed a child from play, our child is concussed, what are we expecting the symptoms to be? So the most common ones are 87% of the time, they'll have a headache, which we're not surprised at. Dizziness may present and difficulty concentrating. Those are the 3 most common. As I said already, only 1% of concussions involve being knocked out, really. So we're not saying, if you come at me saying, or come at one of the trainers saying they weren't knocked out, it doesn't matter. All right? Next one is that up to 30% have delayed symptoms. So what those are likely to be is a lower hit or a lower impact hit whereby the inflammatory cycle or the physiological reaction is more subtle and takes more time to actually be felt or to rear its head, should we say. Next one is we have, in terms of the, let's say the concussions come on, they come off pretty quickly. So 50% of them resolve within a week, 90% with resolve within 18 days. That is from old data, wherein this was where we used to just put them into a dark room for 2 weeks and see how they got on. Whereas now, and I'm going to talk about this later on, we get people moving a lot more quickly, we get people individualized specific rehab, and we also reduce the anxiety around concussion. So I would hope and expect that those numbers plummet in the next 2 or 3 years. What we normally see is 3 to 5 days concussions start to get better, with the vast majority, with the overwhelming majority. Last one then is that females can have more pronounced concussion symptoms and take longer to recover. That's due to potentially having slender necks, whereby there's more axonal shearing in the brain. That can be due to the fact that it's during the late luteal phase of the menstrual cycle and the brain has more vulnerability to head impact events. It can be for multiple different reasons. But we know the female symptoms often last longer than male symptoms. Now, so let's say you have a concussion and a concussion happens, and we might just see how he gets on, how she gets on. One is that you've got a concussion and you try and play on, you're at a higher risk of injury, either to your brain or to something else, because you're not going to be moving appropriately and understanding the game appropriately. Next is that you're going to have worse symptoms. So that physiological reaction that you get after concussion, what happens when you exercise, and the really positive thing about exercise is it increases blood flow to the brain. A bit like playing on a rolled ankle or running on a rolled ankle, it's going to swell more and more and more and more and more, and your symptoms are going to be worse and worse and worse and worse and worse, and are going to last for longer and longer and longer. All right. Last one is that, let's see how they go. For coaches, it's poor performance is unfortunately a lot of how we convince them to come off, because they're not just performing as they should be. So loads of reasons to get them off, but again, it's trying to catch them is where we are. So that's why it's like Where's Wally? High impact events in a chaotic scenario that happen at high speed. Now, when it comes to the management, we're not going to spend too much time on this. It's get help, let a medic control the scene. Don't move the player if the player is lying on the ground. Let's let the trainers look after it, and then check for the red flags. The main ones are worsening symptoms and repeated vomiting. Right, when it comes to concussion assessment, the unfortunate thing about the AFL guidelines is that it says that a doctor must be involved in a doctor is the person to clear them for concussion. It doesn't say anything about the assessment really, but GPs are extremely busy. They're treating loads of patients. They don't have a lot of time. But the more that we've seen about concussion in the last few years is that you should treat the assessment like a dinner. It should be varied, it should have components from everywhere, and it should also satisfy whoever's eating it. So, concussion assessment must be multifaceted. So it can't just be the SCAT-6, which is that symptom checklist, knowing where you are, numbers, words, all that kind of nonsense. It has to be multi-components. So what we do in Foundry is we have the SCAT-6, we have a vestibular oculomotor screen. So if you watch ER or watch any of those medical dramas, it's tracking fingers, it's seeing if your concussion is vestibular, if it's more oculomotor, or if it's more somatic in nature. So it allows us to see where rehab needs to go. Next thing is having a look at the neck, because what we can often see with the neck is that if you have symptoms in your cervicogenic area or your neck area, that can mask symptoms in the head. You then have a bit of balance, and ideally we have video footage where available. Obviously at this level that may not be the case. So you're testing multiple systems, and the ideal time is 0 to 3 days. Why that time frame? Because concussions happen, people are symptomatic, and it's not nice having symptoms here. Headaches, dizziness, sensitive to light, and not necessarily knowing what's going on. It's great to have someone to come in early and say, right, this is what you can do, this is what you can't do, this is what you should be doing. All right. Last thing is this can be done by a doctor, but I've yet to see a doctor that's not a concussion specific clinician do an assessment like this, or a suitably qualified physio. Not every physio can do this. So again, you're stuck between two benches. So what we do in Foundry is we have the most robust concussion assessment in Victoria. And I can stand over that, because it was the reason I was brought all the way from sunny Ireland. What we've also done is in FA, in Foundry Athletic, we brought in what's called a Neuroflex. So a Neuroflex is a virtual reality helmet that allows us to get an objective measure on concussion, an objective measure on multiple aspects of concussion to A, diagnose, B, rehabilitate, and C, clear to return to play. It's an incredible piece of kit, and it's one of the ones that I researched heavily. Now, in terms of the approaches to concussion, there's three. It's a bit like any injury. There's three approaches. First is ignore it, put the head in the ground. Symptoms last longer. You have a higher risk for re-injury because you're going back without any sort of reload or any sort of guidance, so you're going off vibes and going off what you feel like doing. And then lastly is that performance suffers in school and on the pitch because you're trying to crack on without any help. So it's a bit like with your back whereby you don't know what's happening, a bit like the hamstring. If you're trying to go off what you feel like doing, you're not going to get anywhere quickly. Next is the GP. So this is what the AFL recommend as a minimum standard. As a minimum standard, go to your GP. So they may or may not confirm the diagnosis. It depends how quickly you get into them and how symptomatic you are and how comfortable they are with assessing concussion. They may give advice around return to school and exercise. They may not. They will likely just throw the protocol at you, which gives you some bland instructions. The last is that it gives clearance for return to play, so we'll come back to that later on. Let's say what we do in Foundry. Now, obviously I'm talking from Foundry this evening, but let's say you're going to another physio clinic and you want an assessment approach to concussion. This is what you need to be getting. So it's a gold standard management by us as well as a GP. We have an in-depth assessment. We have advice on how to resolve symptoms as soon as possible. We have advice on return to learning. We have advice on return to exercise, and we program a progressive return to play, minimizing risk of re-injury, and most importantly, minimize anxiety around return to play. So, management of concussion. What's the three pillars? First one's the most important. We don't even care about getting back to play. First one is get back to normality. So let's get back to, living life normally, seeing friends, going to school, hanging out, having dinner with the family, feeling normal. That's what we want to get initially. Next is we want to get back to normal school and back to play, which normally happens day 7, or ideally as soon as you're asymptomatic. We'll come on to that in a few minutes or in a few moments. Last, and the biggest one, is reduced risk of re-injury. That's where we're focusing on. So, you've gotten a concussion, you've come home from Bowie, you don't know what to do. This is what you do for the first 2 days. So in addition to contacting us or contacting a medical healthcare professional, this is what we do. So the first 2 days after concussion, you limit screen time. If a kid is on their phone for the first 2 days after concussion, that elongates symptoms because it challenges their ocular system, which oftentimes after concussion is affected. So limit screen time, not none, like they have to chat to you if there's an emergency, that's fine, but limit it as much as possible. Go for a small walk on so let's say day 0 is concussion day. Day 1, let's get them out and going for a walk. These days of dark room, don't do anything, oh my God, they're done. Day 1, let's get them moving because exercise helps the brain and exercise reduces anxiety. Next is to eat well and sleep well. So again, an old tale that I was told it happened to me with my dad when I was younger, whereby I had a concussion about 8 o'clock at night, went to ER, and then I was told to be woken up at 3 a.m. So it meant 2 things. Neither my dad nor I got any sleep. And that has been shown to elongate symptoms. So sleep through the night. If you notice that they're worsening, they'll let you know. You can check on them, but don't be interrupting their sleep. Let's get that 8 hours. Now, exercise is golden. What we were told in when I was studying physio for my master's is that if exercise was a pill and people could sell it, it'd be the most expensive pill on the market. It improves metabolic health, improves cardiovascular health, improves mental health, it improves joint health, it makes you feel brilliant, it's class. So when it comes to, and I don't want to get too into the weeds here, so when it comes to concussion, exercise is incredible. It helps that, in short and in its simplicity, it flushes the brain. So those nasty chemicals that come on after a concussion, we increase blood flow and we basically flush them away, which is a really positive thing. What it does is it increases the generation of neurons if they were damaged. It increases generation of new blood cells, and I'm aware that I'm talking about neurophysiology here, so I hope Fiona's not going to call me up on this. Increases neuron connections, it enhances the repair of the brain, and ultimately improves recovery. So that's why exercise. Is there a question there?
Question in terms of like intensity of exercise?
We'll come on to that now in a moment. We're going to, literally it's the next few slides I think. But to put it bluntly, it's a very gradual reintroduction at a level that they feel comfortable with. So when it comes to the approach, so the first thing is that the AFL have put out this protocol. So you have the 11-step standardized protocol that it is day 2, it's a bike, and this is on the AFL website that I have links to at the end. Day 2, it's a little bike or it can be a little jog. Day 3, it's a longer jog. Day 4 or 5, it's a big run and a gym session. Day 6 or 7, it is a big, significant run that really challenges the athlete to ensure that their heart rate reaches its max and that they don't get any symptoms from that. So again, we not attack them, but we heavily promote exercise in the early stages to maximize symptom resolution and minimize anxiety. All right, so it's in a nice gradual stepwise approach that we can guide you through. In addition, let's say they have dizziness or they're experiencing ocular symptoms, we have IM balance rehab. When it comes to getting them back into play, it's not just 50% of training, 75 and then 100. It is a return to contact progression that's gradual. Return to learn guidance, we're going to come on to in a moment. And then we also have neck strength. We normally throw neck strength at everyone because everyone's going to benefit. Now, when it comes to getting them back into school, this is done alongside exercise. So it's not a one or the other, it's alongside. Do both all together all at once. First one, what I normally advise is, first day is half a day, interspersed classes. If your child feels good, feel free to push that 1 or 2. Then, secondly, is a half day consecutive classes. Third day, full day, interspersed classes. Fourth day, fifth day, full day. Okay? So that's pretty blunt, but it speaks to a progressive reload to normal life. And that's what we're looking at. So, when we reintroduce a child to school, it's going to challenge them cognitively. It might challenge them with their eyes. When we reintroduce them to sport, it's going to start to spike their heart rate. And if they're doing drills they haven't done before, it's going to spike their cognition. So they might get symptoms. But providing that during that first week, the symptoms are 3 out of 10 or less. So 0 is I have no symptoms. 10 is these are the worst symptoms I could possibly have. As long as they're 3 out of 10, and they go away as soon as they finish, that's fine. So let's say that, day 2, and Niall is in history, and Niall gets a headache. That's 2 or 3 out of 10. I finish the history lesson. I take a little break. Provided my symptoms come back down, I can keep cracking on. So these days of, if you feel anything, you have to stop, that's done. Because what we'd like to do is we'd like to stress the brain. It's a bit like in the gym, if you feel a muscle that's weak and you feel it work, it's the exact same with our approach to concussion. We like to push things early to minimize the time to normal life. Is our new attitude, is the new attitude when it comes to concussion. And again, providing it's less than 3 out of 10, and providing your base level symptoms don't change, and providing it doesn't get worse than that, you can crack on. Now, when it comes to, let's say, return to play clearance, this is received from the GP. The GP has a form that they need to fill out, and then you need to bring that back to the club. That's what the AFL is mandating. But what we know is that symptom-free does not equal RTP. Just because you feel good doesn't mean that you are good. Because we know that let's say the metabolic cascade here, or the deficits from concussion can be more long-lasting than your feelings, all right? And when it comes to any injury, for any sport, these decisions or these aspects all feed into it. How's the athlete feeling? What have they done? What haven't they done? What are they anxious about? What's their load like? What's their strength like? There's loads of aspects that determine return to play for any injury, especially for something as significant as concussion. Now, so the big takeaway is active rehabilitation. It's no longer 2 weeks of doing nothing and then a gradual build up. It's the 21-day protocol that culminates in a game. So we build from nothing all the way back to normality. In terms of school, in terms of exercise, in terms of gym, in terms of fitness, in terms of contact, in terms of training. It's that gradual progression is what we need. And it can be done early from the bike. It can happen with the oculomotor rehab. It can be done with meditation if we're struggling with anxiety around it. It can be done with a bit of running. We then get them back in the gym and doing neck strength work, and then we get them back into contact scenarios to make sure they can tolerate it. Now, this is the big sensitive topic around concussion. So there absolutely is a link between head trauma and neurological injuries, neurological diseases later on. Like, there absolutely is a link there. And there was a huge debate over this for the last 10, 15 years. And it's in my head, it's been confirmed, but they've done systematic reviews now over the last 2 or 3 years using equations to basically show that head trauma has a link with neurological dysfunction later on. but it's a dose-response relationship, is the theory, whereby the more you get, the more likely you are to have it. The more you get, the higher your risk. So the NFL have done studies that have shown that if you have more than 3 concussions, you're more likely to sustain Alzheimer's, dementia later on in life. Now, when I say that, NFL as a sport has a huge head impact burden. So you can hit your head between 500 to 900 times in a season. And a lot of players will be playing 10, 15 seasons. Think about how many times you hit your head within that, in a heavy contact scenario. So, the theory that's at the moment is that when you get concussed, you then have the neurometabolic cascade, which lasts for, can be a couple of days, all the way to 28 days and longer. But it corresponds really nicely with your symptoms. So that needs to be rectified. That needs to be returned to normal, which is what the blood biomarker work is now doing prior to reintegration towards return to play. So if we go back in that, when that neurometabolic cascade, that physiological reaction is happening, the brain is at increased vulnerability to concussion. It's at increased vulnerability to head impacts. And therefore that kicks on the physiological reaction again, a bit like going back with a hamstring and you tear it again, and you tear it again, and you tear it again, that leads to scar tissue. So that's the research wherein this was done is in sports that no longer exist. Because concussions were either A, undiagnosed, B, unreported, or C, mismanaged. Once you feel good, you're good to go. Whereas what we're going to see now, I would hope, is in the next kind of 5-10 years, we're going to see that the rule changes that we brought in, the new approach to concussion, the new respect that we've given to concussion is going to, I would hope, minimize the risk of a long-term neurological dysfunction in later life. Because you hear in rugby in Ireland at the moment, we have the lawsuit wherein players sustain multiple concussions and they, again, mismanaged, undiagnosed, unreported. So you cracked on. And therefore the brain's at increased vulnerability. So that is the first point. As I said, different treatment approach now towards concussion. We treat concussion with respect, ensure you're ready to go back ensure you're ready before you go back, being honest with yourself and others, and again, if in doubt, sit them out. So we take no risks. What the other thing as well to bear in mind is that when it comes to the brain diseases like Alzheimer's, dementia, not necessarily CTE, with brain dysfunction, exercise reduces one's risk of those nasty illnesses. So when it comes to taking a child back from sport like that, it reduces, potentially social exposure. It reduces potentially exposure to exercise and motivation to exercise. So I think sport does overwhelming good. Rugby, soccer, AFL does overwhelming good. So there's a new approach now to concussion than there was. There absolutely is a link between head trauma and CTE, which is called chronic traumatic encephalopathy. There absolutely is a link, but we treat concussion with respect, we return people when they're ready, and we reduce risk of injury by the ways that we know how. And I'll absolutely be able to take questions on that, and I'm sure Fiona will have some questions as well. When do we refer on? So I'm a mere physio. When do we refer on to a sports doc or to someone like Michael McDeasy, who's the concussion specialist in Melbourne? So the rules we use at home, and we use them here, is 2 concussions in 3 months, 3 concussions in a season, 5 concussions within a career. If you have pre-existing complicators like mental health and neurodivergence, whereby what we know is that the symptom trajectory or the symptom longevity or the symptom presentation is different. So if it doesn't walk as it should walk, then right, let's get this referred on and see what we're missing and see what else needs to change. I know I'm doing this at the moment with someone who suffers with, she has anxiety, depression, and bipolarity. So the first thing I did, as soon as I found that out, was I wrote a referral. We're treating her as her symptoms allow, but we have her GP linked in, we have her psych linked in, and then we also have a specialist, a sports doc linked in as well. So we make sure that when we see something we need to deal with and deal with properly, we're straight on it. If there's symptoms from more than 2 weeks, so let's say you're treating a back that doesn't get better with a bit of exercise, a bit of soft tissue, we give a bit more exercise, it still doesn't get better, we might refer for an MRI. Something similar for concussion. If we treat concussion optimally with exercise that is tailored and rehabilitation that is tailored for their symptoms and tailored for their subtype, and they don't get better or they get worse, and let's say we reanalyze and we recontribute and they get worse, that's when we refer on. The last is that we recognize the concussion has a lot of anxiety, so if you feel it's needed, we'll always refer on. We have no issue with doing that. It's easily done. When to take a break, when to hang up the boots. So again, this is extremely up for debate, and this is, let's say, this is where it's coming from rugby union in Ireland, professional rugby union in England. This is where we use. So symptoms lasting longer despite appropriate rehab. All right, so let's say someone who's had a long concussion history, who's gotten another concussion and the symptoms start to linger for a while, done. Next is a lower threshold for an injury. So we had a player in Ireland whose first concussion was a shoulder to the head, not clean out. His next concussion was similar to the first Nanu video, was an upright head impact event. His third one, he just got kicked, like the ball hit him in the back of the head when he was running from a kick, out like a light. So, and there was concussions in between, but those are the three that I saw, whereby the threshold, the force required to elicit concussion, went like that. And that's when the brain has increased vulnerability to concussion, and that's where we can say pull back. And that's where the instrumented mouth guards that are coming in, that measure acceleration, that you see in the AFL and AFLW, are going to be hugely, hugely important. 3 within a year, we always get them reviewed, and they're often told to take a break. 5 within a career, always get them reviewed. Sometimes they're told to take a break. Now, another important facet to concussion identification and concussion assessment is having a baseline. So when the baseline was just SCAT-6, which is the symptoms, a few questions about day, time, all that kind of nonsense, few words are remembered, and a bit of balance, that's ultimately useless. The SCAT-6 changes from, let's say, day 0 to day 14 on everyone. So it's an unstable test that lacks sensitivity and lacks specificity, i.e. it's feckin' useless. So what we do in Foundry is we have a multifaceted approach to baseline testing, wherein it's not just the SCAT-6. SCAT-6 is important because we get the symptoms, but we have our neuroflex, we have our neck strength, we have our fall assessment, we have our chat about schedule, we have our chat about the gym, so we identify what normal looks like for you. And then if it is ADD, ADHD, depression or anxiety, it's important that we know what your baseline is, so then we can get you back to that. And then also, it means that we know you, that if we do unfortunately see you for a head impact event or for a concussion, it means that we know you and we know where we need to go. And we already know where the goalposts are. It increases concussion assessment sensitivity. This is well proven, albeit with just the SCAT-6 and that ocular motor assessment, that increases concussion sensitivity assessment by about 10%. Just by adding that in on top, which is class. And then the more you do, the more obvious it is to identify concussion. We find a reduced risk factors, especially when it comes to neck strength. Hugely important, especially in female athletes. We're doing a good bit of work with Monash University at the moment, wherein we're doing data collection for future research. And most importantly, it's a chance. So when a patient comes into me in clinic, I normally say this is a chance for 3 things. Firstly, is a chance to diagnose what's going on. Second is a chance for us to get a plan for what's going on. And the third and the most important thing is a chance for you to ask any questions you might have. And the same thing applies for this. It's really, really important to come in and ask all the silly questions we're maybe afraid to ask tonight. All right? So I'm going to, in terms of summary, just going to sum up now. So I'm sure I've been talking for too long. The summary is get them moving early. Exercise early doors. Sleep well. Avoid screens the first day. And see a doctor or physio for advice around rehab. All right? And it's not just they have concussed, go away. They need to know what they're doing. Okay? You should never leave. You should always leave having questions, but you should never leave not knowing. You shouldn't leave not knowing what you're doing. So having a distinct plan for what am I doing today, or what can I do for this week? What am I doing on this day? What exercise can I do? What exercise can I do? Do I need medication? Do I need any supplements or anything like that? It's important we can answer all these questions. So make sure that if you have questions, you ask them, and we'll answer them. The only dangerous concussion is the one that's mismanaged or the one that we ignore. So again, there will be events all the way through Australia and in the AFL at all levels across sport whereby players are removed from play and they're absolutely fine. But it's about trusting the trainers that they're looking after your kids. No one here is going to make the AFL in the next 12 weeks, 6 months. So let's make sure we're looking after kids. Let's make sure that if we do have a significant head impact event, that we respect that and we return them gradually thereafter. Because we know that even in scenarios whereby you have a significant head impact and you may not be symptomatic, we know that that is what's called our subclinical impact. And those also count. The volume of those in terms of head trauma also counts. So trust trainers, if in doubt, sit them out. Now, there's a booking link here for anyone